Hello and welcome everyone. This is the first video of a series of videos that will cover rapid fire pharmacology review, and this first series will focus on the antimicrobials. By the end of this video, once you have mastered these antimicrobials, you will be able to score greater than 80% on all of the questions that are relevant to antimicrobials on your STEP examination. If you like this content, please like, share, subscribe and follow for more. So let's begin. So first of all, we have the antibiotics, and in the antibiotics, or you can say the antibacterial drugs, the first one of course that comes to mind are the beta-lactams, which means the penicillins, right? So if they ask you that if a patient has been given a particular antimicrobial specifically for suppose some abscess, skin infection, right, and they ask you for the mechanism, the mechanism of penicillins is going to be DLA analog that binds to the penicillin binding proteins transpeptidases and inhibits cell wall synthesis. So we are going to look at all these mechanisms in the form of a diagram. So let's focus over here. So this is the basic bacterial cell wall that is composed of these subunits. Here you can see these DLA subunits, right? So these are, you can say, the building blocks or the Legos that are getting cross-linked in the form of a peptidoglycan. And once these are cross-linked, they are making the basic structure of the bacterial cell wall. So there are a few keywords that I will tell you that you have to remember for your examination, because our test takers are expert at twisting these words and giving us different form of verbs. So anyone who has memorized one particular mechanism of action is going to be thwarted in the examination. Therefore, we have to know all the different variations which they can use in order to test us for the mechanism of action of these drugs, right? So one is that you are going to remember that they prevent the cross-linking of peptidoglycan, which are the DLA subunits, right? So this is one thing that you will memorize. The second thing will be they act on the bacterial cell wall and inhibit the bacterial cell wall synthesis. The third thing that you will memorize is that they bind to the transpeptidases, which are also known as the penicillin binding protein. So this is basically these transpeptidases. You can remember them as basically being the machinery or the construction machines that are actually bringing these two DLA subunits together. So they basically attack this machinery, these transpeptidases, and they block this machinery from bringing the building blocks, that is DLAs together, right? So the 3 main things you're going to remember. The first one would be blockage of the cross-linking of peptidoglycan, that is the DLA subunits. The second thing would be inhibition of the bacterial cell wall synthesis. And the third thing you're going to memorize is that they bind to the transpeptidases, also known as the penicillin binding proteins. And the fourth thing after that is that these penicillins basically have a beta-lactam ring, and therefore they are DLA analogs, right? So just like the DLA that are actually present in the bacterial cell wall, they are being cross-linked by the transpeptidases. Of course, in order to bind to the transpeptidases, they must resemble those DLA, right? So they are DLA analogs, or they basically have a beta-lactam ring, right? So once you have this picture in mind, screenshot this and put this in your notes so that you will remember all these 4 keywords that I just told you, that they are DLA analogs. Number 2, they bind to penicillin binding proteins or transpeptidases. Number 3, they inhibit the cell wall synthesis. And number 4, they block this transpeptidase mediated cross-linking of the peptidoglycan, right? Okay, next is the mechanism of organism resistance. Now this is also extremely high yield and important, so please pay close attention to it, and this is also confusing for a lot of students. So I'm going to make this very simple by this simple diagram, right? So in this simple diagram, I have represented 4 different types of bacteria. Bacteria 1 with the green, the most, you can say, the sensitive or the most innocent of the bacteria. Second one with this orange, right, which is a little bit more resistant. Third one with the red, even more resistant. And fourth one with the brown, which is most resistant, right? And we will go through them step by step in one diagram. And again, you can take a screenshot of this picture so that you can fix this image in your head, because this creates a lot of confusion. So what was altered in the bacteria and what did it develop resistance in? Okay, so let's begin. So this is our first most innocent bacteria, which is basically sensitive to penicillin. So penicillin basically means it includes both amoxicillin as well as ampicillin, right? So the first bacteria that is sensitive to penicillin is just sensitive to penicillin, right? So what does it do differently that it becomes resistant to the penicillin, right? So it becomes resistant to penicillin, or you can also say amoxicillin and ampicillin, right? So it's basically resistant to the simple beta-lactams, right? But at the same time it becomes resistant to them, but it is sensitive to the methicillin class antibiotic beta-lactam. So which are the methicillin class? They are the oxacillin, dicloxacillin, nephicillin, right? So this is step number 1. How does a bacteria that is basically sensitive to the penicillins, right, become resistant to the penicillins, but at the same time remains sensitive to the methicillin class? And which are the methicillin class? The oxacillin, dicloxacillin, and the nephicillin, right? So this first mechanism is the production of beta-lactamases. Now I just told you that the penicillins basically have a beta-lactam ring. So if the bacteria starts producing a beta-lactamase, that is going to attack the beta-lactam ring that's present inside the penicillins, and once it attacks it, it's going to dissolve the penicillins, right? It's going to degrade it. So that's the first step. Embed in your mind resistance, first sensitive to penicillin, 2 becoming resistant to penicillin, but at the same time being MSSA, that is sensitive to the methicillin. Okay, now step number 2. This MSSA, which was at this time sensitive to methicillin class, that is oxacillin, dicloxacillin, nephicillin, but now it's becoming this red bacteria, more dangerous bacteria, which is MRSA, right? So MRSA basically means it is becoming resistant to the methicillin class, which is oxacillin, dicloxacillin, and nephicillin, but it's still sensitive to vanco, right? It's still sensitive to vanco. So MSSA is converting into MRSA, and then the mechanism of action is basically altered PBP. So first mechanism was sensitive to penicillin to MSSA, and that was beta-lactamase. From MSSA to MRSA, that is altered penicillin binding proteins. And now is the third and the final step. How does a bacteria that is MRSA, resistant to the methicillin but still sensitive to vanco, so sensitive to vanco gets converted into resistant to vanco, right? So the third step is basically by converting the D-ELA in subunits in the cell wall into D-ELA, D-LAC. And once we will do the mechanism of action of vancomycin, we'll come to know that, oh, vancomycin actually directly blocks these building blocks, D-ELA building blocks. So the bacteria becomes so intelligent, and it changes the building blocks, so penicillin cannot bind, the vancomycin cannot bind those building blocks, and it gets converted, it makes the subunits convert to D-ELA, D-LAC instead. So please memorize this. This is extremely high yield for examination. Okay, let's move on. So the mechanism of organism resistance, we have already done it in the flow chart, so we are not going to do that again. Let's move on. So as we have talked right now, the 90% of the community acquired staph that we have are actually MSSA, right? So only 10% are MRSA, whereas 90% are MSSA. So what do you think? These 90% of MSSA, if you are sitting as a primary care physician at an office, right, and a person presents to you with most likely a staph infection, stain infection, should you actually be giving them penicillin, amoxicillin, or ampicillin? No, because the majority of the cases are MSSA, right? Remember the MSSA in this diagram? So they basically are resistant to the ampicillin, amoxicillin, or penicillin. So what are your options? What should you give to this patient instead? So the first option is that either you give to this patient amoxicillin with clavulinate or ampicillin with sulbactam. So if he is getting something IV, then ampicillin sulbactam. If he's getting something per oral, then amoxicillin clavulinate. Why would that be? Because these MSSA, the 90% of the community acquired staph, the MSSA, they basically have beta-lactamase, right? So because they have beta-lactamase, we need to add a beta-lactamase inhibitor. So then it's going to prevent the degradation of the antibiotic. Therefore, we must give either the first option is that if you are suspecting that this patient has a community staph infection, first option, give him amoxicillin clavulinate per oral or ampicillin sulbactam IV. Or you have the second option for you is that you don't even give penicillin or amoxicillin and instead directly go on to the methicillin class antibiotics. And the methicillin class antibiotics would be you either get dicloxacillin, fluoxacillin, or nephicillin, oxacillin, cloxacillin, right? So that of course, like they are highly steric, so they have basically, you can say, increased resistance to the beta-lactamases. They are not easily destroyed by the beta-lactamases. Therefore, these drugs can be safely used for MSSA. And another VNA would be that whenever you have a skin infection like cellulitis, erysipelas, impetigo, right? So that can also be MSSA. So you are not going to give penicillin and amoxicillin. Of course, in the NBME examination, for your practical purposes, please consider other sources. But these are also all things that you are going to use for your step examinations. Okay. Okay. Next off, we have if the question asks you that which is the most common causal organism for cellulitis and impetigo. So impetigo is basically the honey-colored crust, and cellulitis is basically the light pink infection that doesn't look so fiery, but it's pretty serious, right? So if the patient has cellulitis or impetigo, which organism is predominant? What's the most common organism? So in that situation, MSSA basically beats strep pyogenes, right? So MSSA is trumps strep pyogenes. But if they ask you about erysipelas, which is basically that fiery red raised subcutaneous infection, then for erysipelas, group A strep is basically more common as compared to MSSA. So if the question asks you what's the classic outpatient treatment for cellulitis, erysipelas or severe impetigo, then your answer would be either oral dicloxacillin or oral cephalexin. And I also told you that you can use co-amoxiclave or augmentin, right? So basically amoxicillin is combined with clavulanate, right? So because it is a beta-lactamase inhibitor. So these are the three options that you have in the examination for cellulitis, erysipelas or severe impetigo. Whereas if the patient is, of course, he has cellulitis and it's widespread and the patient is diabetic and he needs to be admitted, then the inpatient options that, of course, you have are IV flucloxacillin and IV cefazolin. And, of course, like the third one I told you, you can also use ampicillin sulbactam, right? So keep this at the back of your mind that for all these MSSAs, the community-acquired staphs, you are not going to directly jump to penicillin, amoxicillin or ampicillin alone, right? And similarly, the first generation cephalosporins that you have, cephalexin and cefazolin, they are also equivalent to the methicillin class beta-lactams in that way that they can basically cover MSSA. And we've already discussed this above in the flow chart that we drew, that if MSSA has to convert it to MRSA, then the mechanism of resistance is basically altered penicillin binding proteins. Okay. Now let's come on to the beta-lactam efficacy. So how do you think, or do you think beta-lactams are very efficacious drugs or they are not very efficacious? So we are going to discuss this by means of an example, right? So the empiric treatment of endocarditis, if the question asks you the empiric treatment of endocarditis, that is basically gentamicin. So gentamicin to cover the gram-negative rods along with vancomycin or ampicillin sulbactam. So the vancomycin or ampicillin sulbactam are basically to cover the gram-positives, including MRSA in case of vanco, or if it's not like MRSA, it's MSSA, then ampicillin sulbactam. So suppose they give you a Vinay and the patient actually came with endocarditis and you started him on vanco along with gentamicin, but now when the culture comes back, it's basically MSSA, right? So it's sensitive to methicillin. So you can safely use ampicillin sulbactam or you can safely use nephicillin. So what should you do? You have already started the vanco. Should you stop the vanco or should you continue the vanco? So the answer to this is that you basically have to stop the vanco and switch the patient to nephicillin. Now, considering that we have heard so many good things about vanco, that vanco is your big gun. So why are you actually stopping the vanco? So the reason for that is that beta-lactams are very efficacious. Vancomycin isn't that efficacious. So as long as the patient doesn't have MRSA, right? If the patient has MRSA, we have no choice. We can't use nephicillin or ampicillin sulbactam, then we have to use vanco, right? But if the patient is MSSA, then of course you are going to go for nephicillin, because in terms of efficacy, the methicillin sensitive for MSSA in terms of efficacy, our methicillin class antibiotics such as nephicillin trump vancomycin in efficacy whenever the case is of MSSA, right? So whenever the case is of MSSA, who wins? For MSSA, a methicillin antibiotics such as nephicillin, cloxacillin, dicloxacillin, they win over vanco. Whereas whenever the case is of MRSA, then of course we don't have an option. In that situation, vanco is basically going to win over our methicillin class antibiotics that are oxacillin, dicloxacillin and all these others that we have discussed right now. Okay, so just remember this, that who wins in what situation, who wins for MRSA and who wins for MSSA. And then there can be another Vinay in which they give you a patient who has syphilis, and you normally know that the syphilis is treated with penicillin, but the patient has a history of anaphylaxis to penicillin, right? And the patient has, suppose he has latent secondary or latent secondary tertiary or neurosyphilis, right? And then they ask you, so they give you different antibiotic options and they ask you which antibiotic are you going to use. So the answer would be to desensitize and still give penicillin. And you would be like, come on, like, doesn't this patient have had anaphylaxis? No, because penicillin is so efficacious, right? Therefore, the benefits of using penicillin in this case trump out the anaphylaxis. And in what situation? This situation is that of syphilis, because the damage that the syphilis organism, the Treponema pallidum, is going to cause this patient, and the efficacy of penicillin for treating syphilis is so much that even though the patient has a history of anaphylaxis, you're still going to desensitize the patient to penicillin and use penicillin in a patient who has syphilis. Okay, so suppose again we have another Vinay in which a patient had endocarditis and he was given either vancomycin with gentamicin or he was given ampicillin sulbactam with gentamicin, and the question asks you that why are you using these two groups together, right? So one answer, of course, is that vanco is going and ampicillin sulbactam is going to give you gram positive coverage, where gent is going to give you gram negative coverage. Of course, that's one valid answer. But another valid answer for this is that because beta-lactams act synergistically with the aminoglycosides, that is, beta-lactams will basically disrupt the cell wall, so they basically open the door for the bank robbery, right? And then we have aminoglycosides which are going to enter the cell, and there they are going to disrupt the protein synthesis. So the inside the bank robbery is going to be done by aminoglycosides, whereas breaking the door is going to be done by the beta-lactam. So in this way, they basically act synergistically and they are partners in crime. Okay. Next off, we can have some other Vinays that are related to the adverse effects of these drugs. So suppose a patient has a history of rash to beta-lactam, right? And they ask you whether we can give cephalosporin or not. So the important high yield point is that this is just a rash, right? So if it's just a rash, yes, you can give cephalosporin because there is less than 10% crossover allergy, right? But the same question worded differently, but now they use the word anaphylaxis. The patient has anaphylaxis to beta-lactam. Can you still use cephalosporins? Of course not. You're going to use some other agent such as doxycycline because anaphylaxis is like, it's too risky. Come on, don't give the cephalosporins. Okay. And the exception is again for advanced syphilis or a pregnant patient who has syphilis, you are still going to, even if the patient has history of anaphylaxis, since the penicillin is so efficacious in treating syphilis, you are going to desensitize the patient first to penicillin and then give the penicillin, right? And then we have another Vinay related to the adverse effects, that there is a 55-year-old male. He was treated with nephrotoxicity for MSSA endocarditis, and now the patient has developed, after the treatment, he has developed a rash and has WBCs on dipstick examination. So the diagnosis is interstitial nephropathy, right? And the important thing that you need to remember is that patient does not need to present with rash. Here they gave, in this Vinay, they gave the history of rash for interstitial nephropathy, but simply if the Vinay gives you beta-lactam or cephalosporin or NSAIDs, memorize these three drug classes. Extremely high yield for interstitial nephritis, right? If you want a mnemonic, make a mnemonic BCN or NBC. NBC might sound like better for the news channel, right? So NBC, NSAIDs, beta-lactams and cephalosporins, whenever they are combined with WBCs or eosinophils in the urine, that is automatically equal to interstitial nephritis, right? And the reason, whenever we discuss the methicillin class antibiotics, I tell you about nephicillin, cloxacillin, oxacillin, but I don't tell you about methicillin. So the reason methicillin is not used clinically is also because it has increased risk of interstitial nephritis, right? And we are not going to confuse this interstitial nephritis with, of course, an acute tubular necrosis. So, for example, there is another patient and he was recently started on an antibiotic for, suppose, endocarditis, right? And now the patient has dirty, muddy, brown granular class. And now they ask you for the name of the drug, right? Or the name of the drug class. So this is basically aminoglycosides, that is gentamicin, and the diagnosis is acute tubular necrosis. So keep these two things separated inside your mind, right? A patient started on antibiotic. So two patients are started on antibiotic for, suppose, again, endocarditis, right? And this patient has just developed a rash with EOs in the urine. EOs, or you can say WBCs, and the patient, of course, has EOs in the blood as well. So there's eosinophilia as well, right? Eophilia as well, right? And this is another patient on antibiotics for endocarditis, but now he instead has muddy brown granular casts, right? Muddy brown casts, granular Yes, the two antibiotics are different, right? The diagnosis is different, the antibiotics are different. This is AIN, acute interstitial nephritis, right? Rash, eosinophilia or eosinophilia, right? And these muddy brown granular cast is basically ATN, right? And if they ask you about the drug that is responsible, that is also totally different. For this, it will be NBC, right? Of course, it can be NSAIDs, but of course, if they said an antibiotic, it's not NSAID, right? So then it's going to be either beta-lactam or cephalosporins, or if it is like muddy brown cast, then it is ATN caused by aminoglycosides. And of course, you know the mechanism of action, because nowadays in step 3, they specifically ask you indirectly for the mechanism of action. So for aminoglycosides, it's going to be inhibition of bacterial protein synthesis, whereas for the beta-lactams is going to be inhibition of the cell wall synthesis. Okay, so this concludes our part 1 of rapid fire pharmacology antimicrobials review. If you found this video beneficial, please like, share, subscribe and follow for more. And please let me know in the comments what you liked about this video, what you would like to improve, or you feel that there are some more topics that you would like me to make videos about. And until the time, I'll see you in the next video. Until the time, happy studying.